Imagine knowing that a patient is at high risk for sepsis hours before clinical symptoms appear. Today, artificial intelligence can detect patterns in medical data that the human eye might miss. In Module 2, the focus shifts from the idea of artificial intelligence to how it actually works in medicine. Artificial intelligence systems do not think like clinicians. They learn from data. Understanding the types of data they learn from, imaging, clinical notes, structured electronic health records, and genomics, is essential for evaluating whether these systems are safe and reliable in practice. In this module, the mechanics behind artificial intelligence systems are examined. How algorithms learn patterns from medical data, how their performance is measured using clinical metrics such as sensitivity, specificity, and ROC curves, and how predictive models estimate patient risk. For physicians and healthcare professionals, the goal is not to become data scientists, but to develop the ability to critically interpret artificial intelligence tools that are increasingly entering clinical workflows. Module 2 provides that foundation. Let's proceed to the 4 chapters.
All right, so if we're going to talk about how AI is going to change your life in medicine, we have to start at square one. And I mean the real square one. Not algorithms, not some crazy math, but the most basic question. What does the stuff actually learn from? What's the fuel that makes the whole thing go? Well, it all comes down to one thing: data. And I really want you to get this right from the get-go. This isn't some futuristic sci-fi movie stuff we're talking about. This is real, it's happening now, and it's going to be a huge part of your residency. This is your future, starting today. Look, you're going to be seeing AI everywhere. It'll be helping you read radiology scans, analyze path slides, maybe even write your notes. But here's the deal. To use these tools without causing harm, you have to know what's going on under the hood. You just can't look at an AI's recommendation and take it at face value if you don't know what it was taught. It's that simple. Okay, so think about it this way. An AI model is basically like you. It's a student. It learns medicine by seeing tons and tons of cases. But here's the crazy part. It can binge watch an entire career's worth of patient cases in an afternoon. So the real question, the one that changes everything, is what kind of cases is it actually watching? So to answer that, we need to look at its curriculum. We're going to break down the 4 main types of medical data it learns from. Think of these as the AI's core subjects in med school. So what's on the syllabus? First up, we've got imaging data. You know, all those x-rays and scans. Then there's clinical text, which is basically all the notes we write. After that, we'll hit structured data, the neat and tidy numbers like lab results, and we'll finish up with the really wild one, genomics. All right, let's dive into those first 2. This is all about how an AI learns to see and how it learns to read. Now, this is maybe the single most important thing to understand about medical imaging AI. When an AI looks at a CT scan, it doesn't see a tumor. It doesn't see a lung. It doesn't see a heart. It sees none of the things that you and I see. So what does it see? Numbers. Just a giant grid of numbers. That's all an image is to a computer. Every pixel in that X-ray is just a number in a spreadsheet. The AI's job is to stare at millions of these spreadsheets and find tiny, almost invisible statistical patterns in those numbers that happen to correlate with a label we give it, like pneumonia or cancer. Okay, next up is clinical text. This is all the messy human stuff. Your progress notes, path reports, discharge summaries. It's just words. And to make any sense of our scribbles and shorthand, the AI needs a special tool called natural language processing, or NLP. And here's why that's so tricky. You might write shortness of breath in a note. Your colleague might just write SOB. We know they mean the same thing, but a computer doesn't. So NLP is basically a translator. It teaches the machine that all these different human phrases actually point to the very same medical idea. Okay, so we've covered images and text. Now let's get into the hard numbers and the even harder biology. Now, structured data. This is the stuff that AI loves. Why? Because it's already a number or fits into a neat little box. We're talking lab values, heart rate, blood pressure, billing codes. It's clean, it's organized, and it's perfect for making predictions. So let's say you're building a model to predict sepsis. It would look at a patient's age, their BP, their white count, their lactate, all these different numbers and crunch them together to spit out a risk score. This is exactly how those alerts that pop up on the ICU monitor work. It's predictive modeling in action. And last but not least, we have genomics. And folks, this is just a whole different ballgame. We're talking about millions of data points for one single patient. A human brain just can't see patterns in that amount of information. It's impossible. But for an AI, this is where things get really, really exciting. It can sift through all that genetic code to find the one tiny mutation that a cancer drug can target. It can predict which patients will have a bad reaction to a medicine. It's the engine that's making precision medicine a reality. So, we've seen what the AI learns from: images, text, numbers, genes. But now we get to the most important part of this whole discussion: the AI's blind spots. Because where that data comes from, well, that turns out to be everything. Okay, if you zoned out for everything else, zone back in for this. This is the one rule to rule them all. The data you train an AI on completely determines how it behaves. Period. It defines what it's good at, what it's bad at, and where it's going to fail spectacularly. You've probably heard the phrase garbage in, garbage out, and nowhere is that more true than here. If your data is biased, your AI will be biased. If your data is missing pieces, your AI is going to be unreliable. And this is a big one, if your data only represents one type of person, that AI could be dangerously wrong for everyone else. So let's go back to our student analogy. Imagine a med student who has only ever seen patients at one single hospital in one single city. They might get really good at treating the people there. But what happens when you drop them in a clinic in a totally different country? With different people, different diets, different diseases, they're going to be lost. They are going to make mistakes. That's the risk we run with AI. So this all lands on you. As the doctor in the room, it's your job to be the skeptic. So before you ever trust an AI, you need to ask these 3 questions. 1. What kind of data did it learn from? 2. What people did that data come from? And 3, what kind of hospital or clinic did it come from? Knowing the answers is the only way you can decide if it's safe to use for your patient. Okay, so today we covered the what, the raw ingredients that AI learns from. Next time, we're going to get into the how. How does it actually find those patterns and all that data? It's going to be fun. I'll see you there.
All right, today we're going to tackle a topic that's honestly foundational for every single future physician. How does AI actually learn? Now, don't worry, you're not going to need to know how to code or anything like that. But what you do need to understand are the core principles behind these tools, because trust me, they are going to shape your career. So let's dive right in. So let's just start with the big question, the one that's going to guide us through this whole explainer. How on earth does a machine learn like a medical student? I know, it sounds a little strange, right? But the process is, well, it's surprisingly similar. And by using this analogy, we're going to break down a really complex topic into something that just makes sense. Okay, so here's our game plan. First, we'll talk about what learning even means for AI. Then, we'll use a board exam analogy, you'll like this one, to see how they're tested. We'll get into the huge difference between memorizing and truly understanding something. Then we'll cover the really serious topic of hidden bias. And finally, we'll wrap up with what's probably the most important piece of the puzzle, your role as the physician. All right, first up, what does it actually mean for an AI to learn? I mean, it's not like it's pulling all-nighters with a pot of coffee, right? But it is a process of exposure, making mistakes, and then refining things. You know, a process you're about to get very, very familiar with. So the fancy term for this is machine learning. And the key difference is this. With old school software, a programmer has to write out every single rule. You know, if this happens, then do that. But with machine learning, the system pretty much learns the rules all on its own. It just gets exposed to a whole lot of data, starts looking for patterns, and basically improves itself through experience. And this is where that medical student analogy really clicks. Think about it. You learn from textbooks, from patient cases, from your clinical experience. Well, an AI does pretty much the same thing. It's just that its textbooks are these gigantic data sets. We're talking thousands upon thousands of x-rays, millions of lab values, endless clinical notes. It's all about pattern recognition, just on a scale we can barely imagine. Okay, so the most common way this happens is something called supervised learning. It's actually a pretty simple 4-step loop. Let's walk through it. Step 1, you feed the AI labeled data. So for example, you give it an x-ray that a top radiologist has already marked up as pneumonia. Step 2, the model takes a guess. It says, I think this is pneumonia. Step 3, you compare its guess to the real answer. And step 4, and this is the key part, if it was wrong, it actually adjusts its own internal wiring to do better next time. Now, imagine doing that 1,000,000 times over. You end up with a model that gets really, really good at spotting pneumonia. So, If that's how it learns, how do we actually test an AI to know if it's any good? Well, just think of it like your board exams. You wouldn't be tested on the exact same questions you saw in your practice tests, right? Of course not. It's the same for an AI. It absolutely has to be evaluated on data it has never, ever seen before. This is, and I can't stress this enough, absolutely crucial for making sure it's safe and reliable for patients. And here's a great way to visualize how that's done. The data gets split into 3 separate buckets. First, you have the training set. Just think of this as all your lectures and textbooks. It's where the AI does all its foundational learning. Next is the validation set. This is like doing practice questions. It's how we fine-tune the model and make sure it's on the right track. And then finally, we have the test set. This is it. This is the final board exam. It's completely new material that gives us a real unbiased grade on how well this AI is actually going to perform out in the real world. You know, this whole testing process brings up a really critical point. It's a trap that honestly gets both medical students and algorithms. And that's the difference between just memorizing the answers versus actually understanding the concepts underneath. In the world of machine learning, they have a name for this. It's called overfitting. It's basically when a model looks like a genius on all its training data, gets a perfect score, but then completely bombs the final exam. So why does that happen? Well, it's because it didn't actually learn the general patterns of a disease. It just memorized the specific examples it was shown, right down to all the random noise and unimportant details. So the goal, the absolute bottom line, is that we need models that can generalize. That means they learn the real underlying patterns of a disease so they actually work on new patients and are clinically reliable. An overfit model isn't just bad, it's dangerous. It's going to fail in the real world. And what's even worse is that it can give you this false confidence in a tool that is just broken. And there's a sneaky cousin to overfitting called shortcut learning. This is when the AI gets the right answer, but for a totally wrong reason. For instance, imagine it learns to associate pneumonia with x-rays taken with a certain portable machine. Not because it sees the pathology in the lungs, but because it recognizes a tiny watermark that machine puts on every image. Or, get this, it might learn that a picture of skin cancer often has a ruler in it, so it starts looking for rulers, not melanoma. It's a clever trick for sure, but it is absolutely not medicine. Okay, we need to talk about something incredibly important now. Maybe one of the most important topics in this entire field, and that's the danger of hidden bias. Here's the thing, an AI model only learns from the data we give it. And if that data carries the baggage of our own history, including inequities in healthcare, well, the AI is going to learn those biases too. This is really the core idea you need to grasp. If you train a model mostly on data from, say, one demographic group, it might just not work well, or worse, it could be unsafe for other groups. Any gaps, any inequities that are in that original data, they get baked right into the model's brain. And that doesn't just replicate our existing health disparities. It can actually make them bigger. Just look at this. This quote is from a huge landmark study. They found a widely used algorithm that was systematically less likely to refer Black patients for extra care, even when they were just as sick as white patients. So what went wrong? The algorithm was using healthcare costs as a stand-in for how sick someone was. But because of systemic issues, Black patients often had lower healthcare costs for the same illness, so the AI thought they were healthier. The researchers found that fixing that one single biased assumption would have more than doubled the number of Black patients getting the critical care they needed. This isn't just a technical problem. This is literally a life and death issue. And that is why you, as future clinicians, have to become skeptics. You have to be critical evaluators of these tools. You need to be asking these questions always. Hey, what data was this thing trained on? Does that data actually represent the patients I'm seeing in my clinic? Was it even tested to make sure it works fairly for everyone? Is this a tool that can be used anywhere, or does it only work at the one fancy hospital where they built it? These are your responsibilities. Okay, all of this leads us to our final and honestly most important point. In a world full of AI tools, what's your role as the physician? The answer is actually pretty simple. Your judgment, your expertise is more critical than it has ever been. This is a distinction you absolutely have to remember. An AI tool does not diagnose a patient. It predicts a probability. It might spit out a number like, there's a 38% risk of this patient developing sepsis in the next 6 hours. Now that's a powerful piece of information, right? You can think of it like a new kind of vital sign. But it is not a final decision. It is just another piece of data for you, the expert, to interpret. At the end of the day, AI is a tool, a ridiculously powerful one, yeah, but it's still just a tool in your bag. The ultimate responsibility, both professionally and ethically, for every single clinical decision that still rests squarely on your shoulders. You're the one who takes that AI prediction and you combine it with everything else you know about that human being in front of you, their history, what they value, your physical exam, and then you make the call. Okay, so let's wrap this up with the key takeaways. Number 1, AI learns by finding patterns in massive amounts of data. 2, splitting data up into train, validation, and test sets is non-negotiable for making a reliable tool. 3, overfitting is just memorizing, not real learning, and that's a big problem. 4, biased data will always create biased AI, and that's a huge patient safety risk. And number 5, the big one, AI predicts, but you decide. Your clinical judgment is and always will be the most important tool you have. And that really brings us to the final thought I want to leave you with. Look, AI isn't some simple yes or no thing. It's an incredibly powerful new tool that's going to be a part of your daily life as a doctor. So the real question isn't if you'll use it, but how. The question for you is, how will you, as a physician, decide when to trust it and when not to? Because your ability to answer that question, well, that's what's going to define the future of medicine. All right, welcome back. In our last explainer, we kind of pulled back the curtain on how AI models learn. But now we've got to tackle what is maybe the most critical question for any physician. Once an AI is trained, how do we know if it's any good? I mean, these are powerful new tools, and before they ever get near a patient, they need a serious, rigorous evaluation. So let's start that process. This quote really just hits the nail on the head, doesn't it? It gets right to the heart of the problem. You see, a high score on a test doesn't automatically mean an AI is smart, or more importantly, safe. In medicine, relying on simple metrics like that can be profoundly dangerous, and we're about to dive into exactly why. So this is the central question for us, right? It just makes sense to treat a new AI algorithm the same way we treat any other diagnostic tool. Think about it. Whether it's a new blood test or some fancy imaging technique, it needs a proper diagnostic workup. We absolutely have to understand its strengths, its weaknesses, and maybe most importantly, where it's likely to mess up. Okay, so our workup for the AI model begins with something that's a lot like a physical exam. And this fundamental first step, this exam, is called the confusion matrix. Now, I know this simple little 2x2 table might look pretty basic, but trust me, it is the absolute bedrock for every single performance metric we're going to discuss. It works by comparing the AI's prediction, which you can see over there on the rows, to the actual reality, what was really going on with the patient, and that's shown in the columns. Every single prediction the AI makes has to land in one of these 4 boxes. So let's break down what each one means, and we'll use a common clinical example, an AI that's built to spot pneumonia on a chest x-ray. First up, we have the true positive. This is the best case scenario when a disease is actually there. The patient has pneumonia, and the AI correctly flags the x-ray as positive. That's a hit, a correct diagnosis. Next, we've got the false positive. You can just think of this as a false alarm. The patient's lungs are perfectly clear, but the AI incorrectly flags the x-ray as showing pneumonia. Now, this can lead to a lot of unnecessary tests, extra costs, and of course, a ton of anxiety for the patient. Then there's the true negative. This is basically a correct rejection. The patient is healthy, and the AI correctly identifies the x-ray as negative for pneumonia. All good here. And finally, we have what is probably the most dangerous outcome of all, the false negative. This is a missed case. The patient really does have pneumonia, but the AI completely fails to detect it. For any diagnostic tool, this is a catastrophic failure. So, now that we've done our physical exam with the confusion matrix, we can start to calculate the model's vital signs. These are the core metrics: accuracy, sensitivity, and specificity, and they're going to give us a much, much clearer picture of the AI's overall health. Let's start with the one that you've probably heard of the most, accuracy. It's super intuitive, right? It just tells us the overall percentage of correct predictions. But in healthcare, you'll often hear accuracy called a vanity metric because, honestly, it can be dangerously misleading. And this is the perfect illustration of why. Just imagine a really rare cancer that only affects, say, 5% of the population. Well, a lazy AI that simply predicts no cancer for every single person is going to be 95% accurate. Sounds amazing, right? But it's clinically worthless because it misses 100% of the actual cancer cases. This is exactly why we have to look deeper. And this is precisely why we need better, more nuanced metrics, starting with sensitivity. You might also hear it called the true positive rate, and that's because it focuses on that true positive box from our matrix. In plain English, sensitivity answers one of the most critical clinical questions we can ask. If my patient really has the disease, how likely is the AI to find it? So you can see why high sensitivity is just absolutely essential for screening tools. When we're on the lookout for conditions like sepsis or an early-stage cancer, a missed case, a false negative, is just catastrophic. We need a tool that is exceptionally good at catching every single possible case, no matter what. Now, the other side of this coin is specificity, or the true negative rate. Specificity answers the opposite but equally important question. If my patient is healthy, how likely is the AI to correctly confirm that? High specificity is absolutely vital for preventing harm from all those false positives. A low specificity AI would just be constantly crying wolf, raising false alarms left and right. And that leads to unnecessary biopsies, a lot of patient anxiety, and a very real phenomenon called alert fatigue, where clinicians just start ignoring the tool because it's wrong so often. This brings us to what I like to call the specialist consult. Because here's the thing, sensitivity and specificity are almost always in a delicate balance. If you try to improve one, you often end up sacrificing some of the other. And this isn't some technical problem for an engineer to solve. It's a clinical judgment that we have to make. And that leads us to a much more profound question than just how accurate is it? The real question we have to ask when we implement an AI tool is this: where are we willing to fail? Are we more willing to accept a false alarm, or are we more willing to accept a missed case? And the answer depends entirely on the clinical context. This slide gives us a perfect real-world example of this trade-off in action. So on the left, for a sepsis screening tool, we have to prioritize high sensitivity. Sepsis is incredibly deadly if it's missed, so we will gladly accept a few false alarms to make sure we don't miss a single case. But now look at the right side. If an AI is helping to confirm the need for a really risky surgery, we have to demand high specificity. We have to be as certain as humanly possible that the condition is there before we do something so invasive. See? The clinical context changes everything. Okay, now for a more global, big-picture view of an AI's performance, we can turn to a more advanced imaging technique, if you will, the ROC curve, and its sidekick score, the AUC. So the receiver operating characteristic, or just ROC curve, thank goodness, is a graph that gives us the whole picture all at once. Here's a simple way to think about it. An AI doesn't just say yes or no. It gives a probability score, like a 75% chance of pneumonia. We then have to set a threshold. We might say anything over 70% we'll call positive. What the ROC curve does so brilliantly is it visualizes that trade-off between sensitivity and false alarms for every possible threshold we could pick. A better model's curve will kind of hug that top left corner, which means it can get high sensitivity without creating a boatload of false alarms. And to make this even simpler, we can actually boil that entire curve down into a single number, the area under the curve, or AUC. Just think of it as one summary score, ranging from 0.5 to 1.0, that tells you how good the model is overall at telling the difference between a sick patient and a healthy one. An AUC of 1.0, well, that represents a perfect model. It can perfectly distinguish between the two groups with 100% sensitivity and 100% specificity. This is the theoretical ideal, the holy grail. On the other hand, an AUC of 0.5 means the model has absolutely zero ability to tell the difference. Its performance is no better than a random coin flip. And listen, this isn't just theoretical. There was a study that evaluated an AI for knee osteoarthritis and found its AUC values were hovering right around 0.5. They basically concluded the model was completely unreliable. This is why we measure. So, what does all of this mean for you as a future physician? Well, it means your role isn't being replaced by AI, it's actually becoming more critical than ever before. You are the one who creates the clinical plan, and that means you have to be able to critically evaluate every single tool you decide to use. So let's wrap this all up with 5 key takeaways for your future practice. Number 1, evaluate AI just like you would any other diagnostic test. Be skeptical. 2, always remember that accuracy by itself is not enough and can be dangerously misleading. 3, sensitivity is your main tool to protect against missed disease. 4, specificity is your tool to protect against overtreatment. And 5, and this is the most important one, AI predicts probabilities. Your clinical judgment is essential. At the end of the day, even the most advanced algorithm can only analyze pixels and give us data. But you, the clinician, you're the one who integrates that data with the patient's story, with their values, and with your own clinical expertise. The AI provides the data, you provide the judgment. Welcome to our final explainer in the series. We have spent a lot of time on the fundamentals of AI, and now it's time to connect all that theory to actual practice. We're going to show you how you can apply this incredible technology responsibly, right at the bedside.
So, over our last few sessions, we've really built this foundation, piece by piece. We started with awareness, just understanding the data itself. Then we moved on to understanding how these models actually learn. And then, evaluation. How do we know if they're any good? Well, this session is the capstone. This is where it all comes together. It's about your professional responsibility when these tools are in your hands.
We're going to walk through this pretty logically. We'll start with the core concept. What even is predictive analytics? Then we'll look at how it's being used today, right now in clinics. After that, we'll talk about its limitations, and we'll end with what I think is the most important part of this whole series, your central role as a physician. All right, let's put it all together. This is where our journey through the theory of AI finally meets the day-to-day reality of patient care. This quote just nails it, doesn't it? It perfectly captures the shift we're making here. Look, your job isn't to be a data scientist. Your job is to be a thoughtful, discerning clinical user. So our focus is moving away from the technical stuff under the hood and toward the practical, professional, and ethical use of these tools in your work. So when we throw around this term predictive analytics in a hospital setting, what do we actually mean? Let's just strip away all the jargon and get to the point. At its very core, it's this. We are using historical data, everything that has happened to millions of patients before, to try and forecast what might happen to your patient next. The entire goal here is to be proactive, not reactive, in how we deliver care. And this right here brilliantly illustrates that conceptual shift. Traditional diagnostics are all about the present. Does this patient have pneumonia right now? This is different. This is about prognosis. It's about future risk. The question becomes, is this patient at risk of developing sepsis in the next 6 hours? See the difference?
And this is a crucial point, so I really want you to hear it. The output from one of these systems is not a diagnosis. It is a probability. Not a diagnosis. It is a probability. It's a number. A risk score. It won't tell you this patient has sepsis. Nope. It will say something like, based on these subtle patterns we're detecting, this patient has a 42% probability of deteriorating. Your job is to decide what to do with that information.
Okay, so let's see how this concept actually translates into real tools that are being used in hospitals as we speak. This isn't science fiction, and it isn't coming soon. According to a 2024 government report, more than 2/3 of hospitals in the US have already adopted and integrated these tools right into their electronic health records. This is already part of the clinical world you're about to step into. So where is it being used the most? Well, a recent systematic review shows that these models are most common where you have tons of data and high-stakes decisions. Think about places like the ICU and the emergency department, where you have this constant stream of real-time data and every second counts. A classic example is a sepsis early warning system. Sepsis can be incredibly sneaky in its early stages. What these models do is continuously analyze all that incoming data, vitals, labs, you name it, to find these subtle patterns that might show up hours before the obvious clinical signs. It's like a tripwire to get you to the bedside earlier. Or take radiology. A busy ER can produce hundreds of scans in a single night. An AI triage tool can look at those images the second they're taken and push the ones with a high chance of a critical finding, like a brain bleed, straight to the top of the radiologist's to-do list. It's not replacing the radiologist, it's supporting their workflow, making sure the sickest patients get attention first. Now, it is absolutely essential that we hold a balanced, critical view of this technology. It's an incredibly powerful tool, but that's all it is, a tool. And like any tool, it has its strengths and, just as importantly, its limitations. On the one hand, yeah, AI has incredible scalability and pattern detection. But on the other hand, we have to be so aware of the downsides. False positives can lead to alarm fatigue. That's when an alarm goes off so often for non-critical things that clinicians just start to tune it out, and then you miss a real one. False negatives might be even scarier. They can create this dangerous false sense of reassurance, no alert must mean everything's fine. And of course, we have to worry about algorithmic bias and the very real danger of automation bias. That's our human tendency to just trust the machine, especially when we're busy. This is it. This is the fundamental principle. This is the mantra you have to carry with you into your clinical practice. These tools exist to augment your clinical reasoning, to give you another data point, but never, ever to replace your judgment. And that brings us to what is, without a doubt, the most important part of this entire series: your non-negotiable role and your professional responsibility in a world where AI is part of the clinical team. The workflow always has to look like this. The model spits out a number. That's its job. You, the physician, provide the wisdom. You interpret that number. You apply the unique context of your actual patient, their history, their values, what you are seeing with your own eyes at the bedside. And then, and only then, do you make the final clinical decision. You have to adopt this critically evaluative mindset. This is what separates a passive user from a truly responsible clinician. You always have to be asking these questions. Was this model trained on a population that actually looks like my patient? Does this result completely conflict with my own gut feeling? And maybe the most important question of all, what are the consequences if this model is wrong? Never, ever turn off your own clinical brain.
And here's the bottom line. Accountability is and always will be human. An algorithm can't be sued for malpractice. It can't stand before a review board. The professional and ethical responsibility for every single clinical decision rests squarely on your shoulders.
Look, this isn't about being replaced. It's about being enhanced. The physicians who are going to lead the next generation of medicine will be the ones who can thoughtfully, critically, and responsibly integrate these powerful tools into their practice. That is the challenge, and honestly, the incredible opportunity that lies right in front of you.
Artificial intelligence in medicine ultimately comes down to three things: data, patterns, and probability. Artificial intelligence systems analyze vast data sets and generate risk estimates, but they do not diagnose disease, and they do not replace clinical reasoning. Artificial intelligence predicts probabilities. Physicians interpret meaning. Understanding how these systems learn and how their performance is evaluated is critical for safely integrating them into clinical care. In the next module, Module 3, Artificial Intelligence in Diagnostics and Clinical Care, the focus shifts from foundations to application. This is where artificial intelligence begins interacting directly with radiology, pathology, laboratory medicine, and clinical decision support systems.